So, um, have you ever wondered what really goes on behind the scenes when, say, a medical authorization gets denied? Or maybe, how widespread healthcare fraud actually is within our system?
hmm
Today, we're taking a deep dive into some really fascinating and, frankly, sometimes pretty concerning documents.
That's right. Our source material for this deep dive includes official letters. These are from the Workers' Compensation Board, and they concern doctors whose authorization to treat injured workers, well, it wasn't renewed.
Okay.
We also have a consent order. This one's from the New York State Board for Professional Medical Conduct. It involves a physician who is facing some serious professional misconduct charges.
Right.
And finally, there's an annual report from the New York State Department of Financial Services. It details their pretty extensive efforts to combat health insurance fraud.
Okay, so quite a range of sources. Our mission today really is to pull out the most important nuggets of knowledge, the key insights from these sources for you. By the end of this, you should have a much clearer understanding of what actually is medical misconduct, how it impacts the healthcare system, the significant ways it impacts it, and just the sheer scale of the efforts trying to combat it. We're going to uncover some surprising facts, maybe some patterns too, that paint a vivid and, yeah, sometimes unsettling picture of this whole complex issue. So let's dig in.
Okay. We're going to start by looking closely at two letters. These are from the Workers' Compensation Board. One's addressed to a Dr. Joseph Weinstein and the other to a Dr. Vadim Lerman. Both letters clearly outline why their authorization to treat injured workers wasn't renewed. And what's really striking here, I think, are the persistent patterns of behavior that seem to connect both these cases.
Yeah, it's quite remarkable when you look at them side by side. Across both doctors, the board cited, and this is a direct quote, a consistent series of non-compliant behaviors.
Right.
Basically, they were seriously deviating from expected standards of care and, the administrative rules too. Their actions often exposed patients to unnecessary risks from invasive procedures. And their records.
Big problem there.
Yeah, frequently lacked adequate or even credible documentation, just failing to meet basic medical record-keeping standards.
And crucially, the procedures they were proposing often lacked sound medical justification or clear clinical indications. Both doctors repeatedly submitted these prior authorization requests, PARs, they're called.
Right, those are the forms you need before you do certain things.
Exactly, you need that approval first. And they were submitting these PARs for services outside of the standard medical treatment guidelines, the MTGs, without proper justification. They also performed procedures in patterns or quantities or frequencies far greater than recommended. Again, no real medical justification. And to top it all off, both showed clear billing irregularities.
Let's maybe zoom in on Dr. Joseph Weinstein's case first, because it really illustrates these issues well. His 2024 Medical Director's Office review, that's the MDO review, his PAR approval rate was approximately 27%.
27%?
Yeah. Now, to put that in perspective, the industry-wide rate is around 54%.
Wow.
Think about that. His proposed treatments were deemed clinically deficient, basically not up to snuff, twice as often as the average. That really makes you question the judgment being applied, doesn't it?
It absolutely does. And one standout example from his case involved an early, pretty aggressive surgery. He recommended a decompression and lumbar disc fusion at L4-5 for a claimant who wasn't even 28 years old at the time of the first visit.
28 for a fusion.
Yeah. And this was proposed even though an MRI and a CT scan were described as unremarkable at those specific levels they wanted to fuse, meaning, only mild disc herniation, no stenosis, no instability noted.
So nothing screaming major surgery needed right now.
Pretty much. And there was also insufficient evidence that any conservative care, like, say, physical therapy, had even been attempted first.
Which is usually step one, right?
Generally, yes. And it gets even more concerning. He actually performed that L4-5 fusion 9 months after the initial recommendation, but there was no clear documentation of the patient's status in that interim period. And then he failed to submit the surgery report to the board promptly.
So delays and missing paperwork on top of questionable decisions.
Right. In another instance, he submitted a PA for durable medical equipment DME for an electrical bone growth stimulator, but it should have been submitted as a special services PAR.
Okay, different category.
Different category, different requirements. And it was for a patient who had no clear indication of being high risk for pseudoarthrosis. That's where a bone fracture fails to heal properly, creates a kind of false joint.
Oh.
And being high risk for that is a specific requirement for using these stimulators. So again, lack of justification.
And what about the documentation you mentioned earlier? Was that a one-off or
Oh no, it was a consistent problem. The report mentions notes being copied verbatim between visits.
just copy-pasted?
Seems like it. Indicating, and this is the board's language again, clinically deficient and inaccurate record keeping, which, as you said, is just fundamental, a breach of basic patient care standards.
Truly alarming. And it sounds like there was this recurring theme of predetermined treatments, maybe.
Yes, that comes up. For a 36-year-old construction worker, Dr. Weinstein had already performed a cervical fusion on the neck. Then he recommended a second spinal fusion, this time a lumbar one, in the lower back.
Wow.
The board explicitly noted that the compounding effect of multiple fusions at such a young age would make it, and I quote, virtually impossible for the claimant to return to construction work.
Devastating for the patient.
Absolutely. And there was no evidence this potentially life-altering outcome was even discussed with the patient. It really highlights a potential disregard for the patient's long-term well-being and future.
The implications are just huge and seemingly overlooked.
Seems that way. And then, of course, we have the billing violations. Dr. Weinstein submitted bills for office visits without actually submitting the corresponding reports to the board. He resubmitted bills that had already been denied for the same services. And he billed excessively, for example, charging $1,300 for a permanency evaluation when the appropriate fee schedule cost was $407.
That's more than 3 times the proper amount. That's a staggering overcharge.
It is.
So, okay, we've seen these patterns with Dr. Weinstein: noncompliance, questionable judgment, documentation issues, billing problems. Now let's shift to Dr. Vadim Lerman. You said his denial cited strikingly similar reasons.
Yes, the broad reasons were very similar, again, emphasizing that consistent pattern of noncompliance. And what's really interesting is how these patterns of what the board called predetermined treatment really echo across both cases.
How so with Dr. Lerman?
Well, Dr. London also recommended what was deemed unjustified invasive surgery, specifically an anterior cervical discectomy and fusion, an ACDF, another neck fusion for a 35-year-old male. Again, without sufficient documentation of trying conservative treatment first or really thoroughly evaluating where the pain was coming from.
So similar jump to surgery.
Right. And the predetermined aspect came in where he was, for example, recommending additional less invasive procedures like epidural steroid injections, ESIs, but simultaneously recommending surgery ASAP.
Wait, recommending injections and surgery ASAP?
Yeah.
That doesn't quite track.
Exactly. It strongly indicates that the conservative measures hadn't really been exhausted or maybe weren't being seriously considered as the primary path.
It is striking how this concept of predetermined treatment pops up again. It makes you wonder, doesn't it, if the focus was perhaps skewed towards the most invasive or maybe most lucrative intervention rather than what was strictly medically appropriate first.
It certainly raises that question. And in many instances, Dr. Lerman repeatedly submitted PARs for physical therapy, but these were denied at level 1 or 2 by the payers, the insurance carriers,
Why were they denied?
due to lack of documentation showing functional improvement or because the request wasn't consistent with the medical treatment guidelines, those established clinical protocols. But what's curious is that these denials were often not escalated by Dr. Lerman to the MDO review, the next level of appeal.
So he didn't fight for them.
He often didn't, which does raise a significant question about the perceived necessity of those requested services. If he didn't feel it was worth pursuing further, how essential was it really?
That's a fair point. And the billing issues, did they mirror Weinstein's case too?
Pretty much, yes. Dr. Lohman also submitted excessive and duplicative bills, sometimes for services of questionable necessity, and he failed to follow the proper board processes for submitting bills. What these cases fundamentally expose, I think, is that critical link between meticulous documentation and ethical patient care. When there's a breakdown in one, it almost invariably leads to compromises in the other, and that directly impacts patients and, well, the integrity of the whole system.
Yeah, it shows a consistent disregard for the established medical guidelines and the administrative standards that are really there to protect patients and make sure care is appropriate. Okay, so we've sort of peeled back the layers on how individual doctors, individual practitioners can erode trust and even jeopardize patient care through these compliance failures, these judgment issues. But what happens when that kind of misconduct escalates? When it goes beyond poor judgment or sloppy paperwork into outright criminal activity? That brings us to a different type of professional misconduct highlighted in this New York State Department of Health consent order for a Dr. Varuzan Dovlachin. This takes us beyond just medical judgment errors and into serious criminal acts.
That's a really critical distinction to make here. Dr. Devlachin was charged with professional misconduct after pleading guilty to a federal crime. Specifically, conspiracy to commit mail, wire, and healthcare fraud, and also conspiracy to distribute and possess with intent to distribute oxycodone and amphetamines.
Wow. Okay, so this wasn't about clinical errors or bad notes. This was deliberate criminal activity, for profit, presumably.
That's what the charges imply, yes, a deliberate scheme.
That's an incredibly serious set of federal convictions.
Hmm.
So what were the consequences for his medical license, his ability to practice?
Pretty severe, as you'd expect. His license to practice medicine in New York State was suspended for 36 months, 3 years. The first 6 months of that was an actual suspension, meaning he absolutely could not practice medicine at all during that time.
Okay.
He was also placed on probation for 36 months, and his practice was severely limited going forward. He cannot prescribe, dispense, or administer any controlled substances, nor can he supervise physician assistants who might be doing so.
Huge limitations, especially given the drug distribution conspiracy charge.
Absolutely. He's also precluded from performing no-fault automobile evaluations or claims, and he can't own or be a shareholder or an officer in any professional medical corporations, basically cutting off avenues used in some fraud schemes.
Makes sense. And I imagine there were significant financial penalties involved too, right? On top of the suspension and probation.
Oh, absolutely. He was required to pay a $25,000 fine. He had to complete 200 hours of community service, and he had to forfeit $50,000. This case, it powerfully illustrates that medical misconduct isn't always just about bad medicine. It can extend far beyond that into serious criminal activities that directly impact public health, public safety, and public funds.
Yeah, a completely different level. Which kind of brings us to the bigger picture, right? The sheer scale of healthcare fraud overall and the immense efforts needed to combat it. This New York State Department of Financial Services, the DFS, their 2024 Health Fraud Annual Report, really lays this out for us.
It does, and the numbers involved are truly staggering. Experts estimate that nationwide losses due to healthcare fraud are somewhere in the range of $30 billion to $300 billion annually.
Billion.
Right.
The B, 30 to 300 billion.
That's the estimated range, yes.
Yeah.
It's a massive drain on the system. It affects everyone, through potentially higher premiums, strained resources.
It certainly is. Just unbelievable figures. So what specific actions is New York State taking? What does the DFS report say about their efforts to combat this massive problem?
Well, in 2024 alone, DFS received 41,686 reports of suspected healthcare fraud. Now, to give you some context for that number, that accounts for approximately 80% of all fraud reports the department received across all types of fraud.
Wow, so healthcare fraud is the vast majority of what they're seeing.
Seems to be, yes. From those reports, they opened 71 specific healthcare fraud investigations, and those investigations resulted in 42 arrests in that year. Furthermore, you have the insurance company's own units, their special investigations units, or SIUs.
Right, the SIUs.
These are the dedicated teams within insurers focused specifically on rooting out fraudulent claims. They reported, get this, $3 billion in savings.
Billion again.
Billion with a B. Savings, meaning fraud they prevented or stopped. And $30.6 million in actual recoveries from their healthcare SIU investigations in 2023 alone.
Those are seriously impressive numbers. It shows how active these units are, both the state and the insurers. What are some of the most common types of healthcare fraud they're detecting? What kind of schemes stand out to you in the report?
Well, what's kind of fascinating here is how a lot of these schemes seem to exploit gaps in billing oversight or maybe a reliance on trust rather than being about actual medical necessity. The report lists several key types. Things like billing for services or products that were never actually rendered.
Just making stuff up.
Essentially, yeah. Charging for things that didn't happen. Then there's something called upcoding. That's where you bill for a more expensive procedure than the one that was actually performed.
Ah, okay. Inflating the service level.
Exactly. They also see medically unnecessary treatments or diagnostic tests being performed solely to generate insurance payments, not because the patient actually needed them.
Right, kind of like that idea of predetermined surgeries we talked about earlier, but maybe applied even more broadly or systematically.
It could be seen that way, yeah. What else makes the list? Misrepresenting non-covered treatments is common, like billing cosmetic nose surgery as if it were a deviated septum repair just to get it covered by insurance.
Sneaky?
Then there's unbundling. That's where each little step of a single procedure is billed separately instead of as one bundled service, which of course inflates the total cost.
Right, breaking it down to maximize the charges.
Exactly. We also see prescription drug diversion and misuse. That's a huge one. Medical identity fraud, someone stealing your information to get care or drugs. Staging auto accidents or slip and fall incidents purely to generate fraudulent medical claims. Filing false or exaggerated medical disability claims. And accepting kickbacks for patient referrals. It's a pretty comprehensive list of the ways the system can be exploited.
It truly is a whole range of dishonest tactics. And the report gives some real-world examples, too, right,
Yeah.
of major investigations that kind of bring these abstract types of fraud to life. What's one that really highlights the, I don't know, the ingenuity or the scale these fraudsters can reach?
Well, one particularly egregious case involved a Medicaid transport provider, someone supposed to be helping people get to appointments. This provider stole over $3.1 million
$3 million. How?
through fraudulent billing for phantom services trips that never actually happened, also billing Greek trips as if they were individual, more expensive trips, and even making up fictitious tolls and parking fees to pad the bills. It was just a complete fabrication of services provided.
Wow. Phantom services, group trips billed individually, fake tolls. That's quite a sophisticated scam. And it's exploiting a critical service for often vulnerable populations, too.
Absolutely. Another compelling example involves someone marketing themselves as a licensed clinical social worker, but they defrauded insurers of approximately $350,000. Again, mostly for phantom services. What makes this case especially alarming, though, is that the individual actually lacked the proper credentials to provide those services in the first place.
So they weren't even qualified to do the work they were pretending to do and billing for.
Exactly, which really highlights the importance of, verifying provider qualifications, not just taking claims at face value.
Yeah, these examples really underscore the creativity, I guess you could call it, and the sheer audacity of some of these schemes. So how is DFS tackling this on a broader level, collaboratively, across the state? You mentioned arrests, but what about prevention and coordination?
Well, DFS works very closely with law enforcement agencies. They have 13 dedicated task forces and working groups across the state. This helps foster cooperation, communication, sharing intelligence to catch these fraudsters. Insurers are also legally required to have their own robust anti-fraud plans and those special investigations units, the SIUs we mentioned.
Right, the mandatory SIUs.
Yes. Plus, public awareness programs play a crucial role too, educating New Yorkers about what fraud looks like, how to spot it, and empowering them to help prevent it by reporting suspicious activity. It's a multi-pronged approach.
Okay, so wrapping this up, what we've really unpacked today reveals this multifaceted nature of misconduct and fraud within the healthcare system. It's quite a spectrum. From individual doctors making questionable clinical judgments, maybe failing on documentation and billing, all the way to these outright criminal schemes costing millions, even billions. These cases really underscore the constant vigilance that's required to protect patients and just the fundamental integrity of our healthcare systems.
And it's important to remember, this isn't just about abstract policies or regulations way up high somewhere. These issues directly impact the quality of care that's available to you, to everyone. They impact the costs you bear through premiums and taxes, and they impact the fundamental trust we all need to place in medical professionals and in the intricate systems that are designed to support our health and our recovery when we're vulnerable.
Yeah. As we've seen, medical professionals, they have this profound responsibility. It's not just to heal, right? It's also to adhere to rigorous standards of care, meticulous documentation, ethical billing, all of it. The information we've explored today, it kind of suggests that in a system as complex, as vital as healthcare, maybe the biggest challenge isn't just catching fraud after it happens. Maybe it's also about creating systems that powerfully incentivize preventative practices. Systems that foster an unwavering commitment to the patient's well-being above absolutely everything else. So maybe a final thought for you, the listener. What further steps do you think could reinforce those incentives? How can we better ensure that the patient's best interest always comes first, systemically?